Okay, hi everyone. I'm so thrilled today to have you all here to listen to the wonderful Dr. Colleen Norris speaking today. Before I begin, I want to acknowledge that we live, work, play, and participate in a community on the unceded, ceded, and traditional territories of the 630 First Nations, each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Toronto, which is covered by Toronto Purchase Treaty Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit Métis who enrich the city, and many of our members live in Vancouver, which is part of the unceded homelands of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I also recognize that many of you are not from Canada, and I encourage you to understand the Indigenous peoples of the place that you now dwell. And please feel free to add anything in the chat to honor those people. This is brought to you by the Women's Health Research Cluster, and just a little very briefly about who we are. We have over 1,000 members across 44 countries. We're really proud of the knowledge translation and dissemination that we do on women's health. It's a growing community. It's free to join. We want to keep it free. We have trainee research presentation series. We're just about to launch a new one, so look out for that. We also have some trainee travel awards. So please look out for that. There's probably going to be another one very soon. If you are a writer, please reach out to us if you have a blog idea. And also, we have Women's Health Interrupted podcast. Season 3 was just completed, and season 4 will be coming up fairly shortly. So please join us if you're not already a member. And thank you to our supporters. And with that, I'm going to stop sharing and read out Dr. Norris's bio while she can share her screen when she so desires. It's a long bio, so we have some time.
Oh, you cut it short.
I'll try, but it's chock full of information. And for you, those of you that don't know, I love to give because the people we have speaking have so many amazing awards and publications. And so I think it's really important for us to give a fun fact of everyone just so that we can bring them down to our level. So I have an amazing fun fact for you today, although my French is not so superb, my accent. So Dr. Norris is an internationally recognized researcher whose work has transformed understanding of cardiovascular health in women. She is a professor and associate dean of research in the Faculty of Nursing with cross appointments in the Faculties of Medicine and Dentistry and the School of Public Health at the University of Alberta. As a Cavarzan Chair in Women's Health Research, Dr. Norris leads groundbreaking program focused on sex and gender-based analysis and the reproductive transition, addressing the unique risk factors and care gaps affecting women across the lifespan. See, doesn't she sound perfect for this? With over 2 decades of research and leadership experience, Dr. Norris has made major contributions to the field of epidemiology, health services research, and knowledge translation. She's had numerous publications, she served on national and international expert panels, and played a pivotal role in shaping clinical practice guidelines. Her research spans health equity, patient-centered outcomes, and the integration of sex and gender into health, research, and policy and care delivery. Dr. Norris is also a fellow of both the American Heart Association and the Canadian Academy of Health Sciences, and a passionate advocate for women's health equity in Canada and beyond. And it's through that lens that I met Colleen first. I'm so proud that I met her. I'm even wearing her pin. It's the Edmonton Women's Health Research pin, and I wear it with pride. So thank you very much for giving me one. I saw her just 2 weeks ago in person when she came to Toronto. Now, Colleen's fun fact. She started school at 4 years of age as a day student in a very English Edmonton, Alberta, at a French Catholic convent. She thought that the reason that you went to school was to learn to understand the teacher. No English was allowed on school premises. Furthermore, her grade 1 teacher let her know that, do you want to say it in French? Tu détestes les Anglais et les gauchères. Is that how you say it? No.
Gauchier.
Gauchères. And she remembers thinking, I'm in trouble as I'm both English and left-handed, right? However, her left hand was tied behind her back So she became right-handed in by grade two. And thankfully she loved school and continued on to it. And I just want to say my dad was left-handed as well in school, and he was also trained to use his right hand. So it's a practice that's been around for a while. Hopefully it's no longer in practice, but who knows? Colleen, please take it away.
Thank you. And yeah, I have two left-handed kids, so clearly I let them be left-handed. There's something in our genes. Thanks so much. I am so appreciative to be here and present today. And I think that women's health depends on every woman really understanding, hearing and understanding, and telling their friends and their daughters and their mothers and their aunts how important it is that we respect and give credit to our ovaries and the estrogen that they produce. So let me just see if okay, so I just have to figure out how to move this.
Advance your slides.
Yeah.
I don't
Oh, there
know.
we go.
There you.
Okay.
Woo. Oh, that's so pretty.
This is a picture of a medicine wheel taken from the Indigenous Corporate Training website, but medicine wheels represent the alignment and the continuous interaction between mental, physical, and spiritual realities. On the website, they actually talk about, I'm just going to make that smaller. There we go. They on the website, they talk that they have identified 46 medicine wheels like this in Alberta. And it constitutes about 66% of the medicine wheels that are known. And so it looks like Alberta is a core area for medicine wheels. Specifically, I think about the Indigenous medicine women who lived and live on the lands across Alberta and the vital role that they've played in their communities, often serving as a healer, herbalist, and spiritual guide. We have very much to learn from them. They utilize traditional knowledge passed down through generations to treat various ailments using natural remedies, including plants and roots and other natural substances. And their practices are deeply connected to the cultural and spiritual beliefs of their communities, emphasizing holistic approaches that consider physical, emotional, and spiritual well-being of individuals. I think I am so fortunate to live on the lands that we live on and to share the medicine and the health that the Indigenous people have passed on to are helping pass on to us. So, oh my goodness, sorry. I don't know why it's doing this today. It will not move for me.
Wants us to dwell on this beautiful picture.
It is gorgeous, isn't it? You'd think I'd know what I was doing. And we even practice this. Isn't this always the case? Just let me figure this out. Next slide here. Okay, today I wanted to talk to you about the estrogen feedback loop in women's health. It may be you already know all about this, but I'm going to review it again. I'm going to talk about aging with estrogen, the importance of cardiovascular, brain, and bone impact of estrogen, and then talk a little bit about the detection and prevention that we can think about as we're moving forward with women's health. So as you can see here, this is the basics of a sophisticated feedback loop that I actually didn't remember from my undergraduate studies in nursing. The hypothalamus in the brain releases gonadotropin releasing hormone to the pituitary gland, and it stimulates the release of follicle stimulating hormone. FSH hormones travel to the ovaries to induce the growth of a follicle. 20 or so follicles are released a month, and the follicle growth increases the amount of estrogen and starts to grow the uterine lining, which is called the follicular stage. That triggers the pituitary to release luteinizing hormone, which triggers the ovulation, and one follicle is released. Releases one egg, and it reforms and becomes the corpus luteum that stimulates luteinizing hormone for the corpus luteum to release pulses of progesterone. If you're not pregnant, the corpus luteum lives for about 2 weeks, dies, drops off the progesterone level, which is a signal for the uterus to bleed and shed the lining. This issue that applies to women's health is that we have completely ignored any disruption in this process has the potential to influence every system of a woman's body. In the past, it was famine or being malnourished or war times led to the ovaries not producing estrogen. And it signaled to the brain not to send out the gonadotropin-stimulating hormone. The brain basically decided this body is not able to carry a pregnancy. It was not a good time to be pregnant, and it shut off the release of FSH. For a female to have sufficient levels of estrogen and progesterone in their bloodstream, for all of their organs, this process of positive and negative feedback must happen in the female body until menopause. And after that, the adrenal gland continues to produce low levels of estrogen and progesterone. The reason that this matters is that the production or lack of production of these sex hormones actually drives women's health. Oh, goodness. I got to figure out a system here so I can just change them without all these problems. I'm so sorry. You think I'd know what I'm doing. So it's time for a paradigm shift. And the statement that the ovaries are the architects of women's health means that the ovaries do far more than control reproduction. They're the central regulators or designers of multiple systems in the female body across the lifespan. And here's what that implies in scientific terms. The ovaries produce estrogen and progesterone, as we said, and the hormones orchestrate the development and function of the cardiovascular, skeletal, neurological, immune, and metabolic systems. These hormones influence arterial elasticity, lipid metabolism, bone density, your mood, your cognition, and even immune resilience. I don't know what's going on. So the ovary, it also has lifespan influence. So ovarian hormones modulate health from puberty to menopause. Their gradual decline, especially the loss of estrogen during the post-reproductive transition, reshapes your cardiovascular risk. It accelerates vascular stiffness. It increases insulin resistance and contributes to osteoporosis and maybe even cognitive decline. Because estrogen receptors exist throughout the entire body, your heart, brain, kidneys, bone, and gut, etc., the ovaries serve as these master control hubs, coordinating communications across all organs. When ovarian function changes, the entire physiological architecture adapts, sometimes maladapts, leading to increased chronic disease risk in females. We've all heard that women live longer than men, but they spend approximately 20 to 25% more of their lives living with chronic conditions and disability, a phenomenon known as the male-female survival paradox. But is that actually necessary? Is that what truth is as far as women's health is concerned? There are also clinical and policy relevance because recognize the ovaries as the architects that reframe women's health from a narrow focus on fertility to lifelong systemic issues underscores the need for clinician education and early hormone monitoring and research investment into ovarian aging and the estrogen's role in disease prevention. In essence, the phrase encapsulates a paradigm shift that the ovaries are not simply reproductive organs, they're the blueprint designers of women's overall health trajectory. This is a statement that Estelle Ramsey said way back in the 70s or in the early 70s. And she was an American endocrinologist, physiologist, and feminist who made significant contributions to the study of hormones and their effect on human health. She's best known for challenging the sexist claims about biological difference between men and women, particularly in response to the 1970s remark by a politician who suggested that women's hormones made them unfit for leadership and disease resistance. The point is that we've known for a while that endogenous estrogen dominates and shapes women's health. And somehow that's been lost in our specialized medical care system. I wanted to just talk briefly about the main types of estrogen and where they're produced. So estradiol is the primary estrogen during our reproductive years. So we're talking 13 to 51 approximately in Canada anyways. And it develops follicles with smaller amounts from the brain and the adrenal gland. It's produced mainly in the ovaries. The key roles are ovulation and menstrual cycle regulation, but also bone, cardiovascular protection, and brain function. Estrogen becomes the dominant estrogen after menopause, and it's produced mainly by peripheral tissues, especially your adipose or fat tissues, through conversion of androgens and smaller amounts from the ovaries and the adrenal glands again. Key roles is to maintain low levels of estrogen activity after ovarian estrogen production declines. Estriol is a major estrogen in pregnancy, and it's produced mainly by the placenta from fetal and maternal precursors. It supports uterine growth and pregnancy physiology. I'm going to be speaking about estradiol today, but it refers to all the estrogens. This is so crazy. I'm going to try a couple of things here to switch this over. Okay, I want to talk about across the lifespan. So we mentioned, I just mentioned this, but the reproductive years, the ovaries are the primary source of the estrogen. During perimenopause and postmenopause, the production declines and estrogen is produced mainly by the conversion in the fat tissue. And then in pregnancy, we talked about the placenta becomes the dominant source of estriol. So there are key trends that we need to understand in follicular reduction. So a female is born with 1 to 2 million follicles. One of the most interesting things that it really blows my mind when I think about this is that when I was in my mom's uterus, I already had the follicles that would produce the children that I have, which just absolutely blows me away. I don't know why. But the follicles reduced to about 300 to 400,000 by puberty. And then there's a linear decline from age 25 to roughly age 37. And the total decline is about 0.4 follicles per year. But then there's this accelerated decline after age 37. So we say the late 30s now. And the rate of decline accelerates significantly. And why that's important is because it's those follicles that are making your estrogens. And so the rate of decline, the rate of estrogen is also declining significantly. So estrogen production shifts from the ovaries to the peripheral tissues as women age. But in 2001, the Staging Reproductive Workshop called STRAW established criteria for the late reproductive stage. And this is actually before perimenopause, which is a part of the menopausal transition. The follow-up STRAW conference further subdivided the late reproductive stage into 2 substages, 3A, which is the rise and increased variability in follicle stimulating, and then subtle clinical cycle changes that occurred before the break in cyclicity associated with the menopausal transition. And so what I'm trying to say there is that there's all sorts of changes that are happening because your ovaries are producing less follicles and less estrogen in your late 30s. But in our world, and as we see it in the medical facility, if you walk in with any of these symptoms that you don't understand, it ends up, the question is always, has your cycle changed? And you'll say, no, it hasn't. And then they say, well, it can't be perimenopause. And we need to understand that it actually is perimenopause, or you're moving into the menopausal transition. This meet Hormone Woman, and she was drawn by the Seattle Research Group to help women understand that there are 400 estrogen receptor sites throughout the body, which is why the effects of low or high estrogen have significant repercussions. Receptor sites include the brain, the muscles, the gut, the uterus, the ovaries, vagina, breast, eyes, heart, lungs, etc., and blood vessels. Estrogen does many, many things, but estrogen is primarily a growth promoter affecting many receptor sites. Progesterone, on the other hand, is made in the ovaries while a woman is still ovulating. After menopause, it's made in the adrenal glands in the smaller quantities. And progesterone receptors are found throughout the body in all the same places as estrogen receptors. Estrogen promotes growth and progesterone promotes calming. Women Living Better investigators in Seattle point out the unpredictability of the late reproductive stage, or perimenopause, which you can see in the middle graph of the different craziness that's going on with estrogen, progesterone, FAH, and LH. The chaotic figure truly represents how I felt in my 40s, but the common wisdom that was that it was caused, and it continues today, that it was absolutely caused by stress. And we'll talk a bit more about that later. This is also really interesting to me, a fact about the late reproductive stage, or perimenopause. Again, the brilliant Women Living Better investigators in Seattle pioneered the work on the perimenopausal symptoms labeled as not feeling like myself. The symptoms correlated with not feeling like myself mostly were fatigue, irritability, low feelings, feeling overwhelmed, and less able to cope, and anxiety. And I remember going to my GP around 42 years of age and saying, I think I'm going to kill somebody. And I honestly did. I had never felt that type of rage. And it was not like my personality, and it felt like it was out of control. And I was so tired of, tearing the head off the person who was serving me coffee and having to go back and apologize for my behavior, that I decided to go to the doctor about it. And the clinician suggested that I could be depressed, and prescribed antidepressants, which actually just made me angry. To be fair, the understanding that emotional symptoms may also be due to erratic estrogen levels, particularly the decreases in estrogen brain receptors, is reasonably new. That even my own research, where I was immersed in women's heart health, we're never looking at the fact that they may be due to larger changes in estrogen, that all of women's heart health issues are related somehow to these changes in estrogen. I don't think it's a coincidence that a study that we did looking at premature myocardial infarctions in women, so women less than 55 years of age, identified that over 70% of the women who had a heart attack experienced profound fatigue 1 month before their heart attack. And this is the type of fatigue where you have to sit down while making the bed. So I want to talk a little bit here about changes in estrogen and what they mean to a woman, the matter of the heart. And this I presented before because, as I said, I'm involved in heart health, but getting ready for this talk and other talks lately, I will show you, but it's also brain and it's bone health and it's all of women's health. So estrogen has antioxidant effects. So oxidative stress in your body is like rusting on the inside of your vessels, and when harmful free radicals build up. And normally antioxidants act like a protective coating, but when they're overwhelmed, damage to cells and tissues occurs. Estrogen has an antioxidant effect. Estrogen blocks the signal that attracts harmful immune cells and platelets, which is the inflammatory process. It keeps your blood vessels stretchy. It increases the good cholesterol, HDL, and it decreases the bad cholesterol, LDL, that clog and damage blood vessels the way grease clogs a pipe. The buildup damages your vessels and causes inflammation, making it harder for blood to flow and increasing your heart problems. And we've always recognized that women's blood pressure starts to increase in their late 30s and 40s and into menopause. And I think it has something to do with estrogen. Estrogen increases the nitric oxide and prostaglandin that relaxes your blood vessels, and it improves blood flow. And it also controls how blood vessels grow and it prevents plaque buildup. Oops, I want to go back one. A matter of the brain, estrogen has neuroprotection for the brain. It shields the neurons from oxidative stress and inflammation, just like it shields your blood vessels. It enhances neuronal survival. It increases serotonin synthesis and receptor sensitivity to stabilize your mood. It modulates dopamine and norepinephrine and supports motivation and focus. It influences acetylcholine activity, which is crucial for memory and learning. It has cognitive function where it promotes synaptic plasticity and dendritic spine growth, particularly in the hippocampus and the prefrontal cortex. I think that's Lisa's favorite spot, the hippocampus. And it improves working memory, attention, and processing speed. It improves your cerebral blood flow. So it promotes vasodilation and perfusion in key brain regions. It supports oxygen and nutrient delivery to neurons. It has thermoregulation, so it stabilizes your hypothalamic control of the body temperature. Its loss contributes to hot flashes and sleep disturbances. It has mood and emotional regulation. It buffers stress response by modulating cortisol release. Low estrogen is linked to anxiety, irritability, and depressive symptoms. And it also reduces amyloid beta accumulation and tau phosphorylation, which is potentially lowering your risk for Alzheimer's disease. It's also, estrogen is a matter of the bones. And you know what? We've known this for a long time. And it's really started to bother me that in Alberta anyways, you can't get a bone density test until you hit 65. And I think that's way too late because now that we know what estrogen is doing and the loss of estrogen is doing to your bones, we should be paying attention to that starting in the late 30s as far as what's happening to your estrogen level and what's going on with your bones. And so it maintains the bone density and strength. Estrogen is a key regulator of bone remodeling. It suppresses the osteoclast formation and activity, and it promotes, slows the rate of bone loss. Again, it stimulates bone formation. It regulates your calcium and vitamin D, which improves intestinal calcium absorption and renal calcium reabsorption. It protects the trabecular or spongy bones, which is particularly important in areas that are rich in trabecular bone, which is your spine, your hips, and your wrists, and the site most affected by postmenopausal fractures. After estrogen declines, bone reabsorption exceeds the bone formation and it leads to accelerated loss. And this loss puts it at an increased risk for osteoporosis and those wonderful fragility fractures that we expect in all frail elderly women. I also wanted to talk a little bit about progesterone here because I started to get into all of this as far as what estrogen is concerned. I have to give a little quick story. I've been working on women's heart health forever and most of my career. And we know that women present differently. And typically, you know, in our Canadian Women's Heart Health Alliance, we were seeing women, we have lots of women with lived experience. And they were telling us things like, I was a runner, or I was a long distance runner, or I was an athlete. And when they present, they are fit and they do not represent what we see as a Canadian community, at least as what a person having a myocardial infarction or heart issues are concerned. And they are fit, they're non-drinkers, all of the risk factors that we think will predict that you'll have myocardial infarction are actually focused on men. And so the women were really surprising us. And so I was really working on how do we get clinicians to understand that a woman who's presenting at 44 or late 40s or moving forward in age, because they're not postmenopausal, they still could have some heart issue that we need to pay attention to. And they're typically, the main causes of heart issues in women are microvascular disease and a thing called we call ANOCA or MANOCA. So there's no blockage in one of the coronary arteries that sits on top of your heart. So it's a different type of heart disease along with a different presentation. But what really struck me is that, you know, we have every year we have Wear Red Canada on February 13th, and we all talk about awareness in women's heart disease, but we really weren't, on our 5th or 6th time, we really weren't making the strides I expected that we would see. And I think it's because we completely disregarded the idea of that woman is going through perimenopause or might have been amenorrheic. I have a wonderful PhD student who is working on looking at the association between amenorrhea and complications of pregnancy, or the vascular complications of pregnancy. I'll talk a bit about that in a minute, but all of these started to make sense to me when I started getting into what reproductive aging actually is, and getting away from my specialized area of heart issues. So just to talk about this, by age 40, your progesterone levels can plummet as much as 75%. And this is like a 5-alarm fire for your nervous system, because progesterone performs over 150 vital functions. The most important role is as your brain's primary calming agent. It works by regulating the GABA receptors and the neurotransmitters to tell your brain to relax. And when progesterone disappears, the brain's stress hormone cortisol spikes as much as 400%. And your nervous systems get stuck in this 24/7 fight or flight mode. And suddenly, your husband is chewing sounds like it's a jackhammer, and finding a parking spot feels like a life or death situation. And you're constantly on edge because your brain is missing the one signal that's saying everything is okay. But the most interesting thing about this is that this is also such a stressful time in a woman's life. Say between the ages of 45 and 55, when everything is happening to them that we've looked forward to as we're progressing through our life, but not paying attention to what actually is going on biologically at the same time. So what in our life are we doing that can cause other estrogen imbalances, aside from the fact that from late 30s on, your estrogen and progesterones are going down? So we need to talk about stress and stress in today's world. It is incredibly important to note that the effects of hormonal changes, particularly the mood changes and the levels of anxiety and cognitive changes, are really difficult to differentiate from concurrent life stressors like caring for your children, managing paid and unpaid employment, being the caregiver for your parents, balancing all these conflicting life roles. And the late reproductive stage or perimenopausal stage is, for me, the most stressful time of a woman's life. And there are research reports that the most commonly reported challenge in midlife women is managing these multiple responsibilities that are attributed to the role. And study again from Seattle Midlife Women's Health Group identified that participants found themselves searching for balance in the midst of multiple occurring stressors while coping with loss and transitions. And when asked in the last 15 years, what was the most challenging, the most commonly reported challenge for a midlife woman was coping with these co-occurring stressors. Not to belabor the point, but please note the red flag that is there, because when one's body is in chronic stress and in fight or flight, the body actually prioritizes the production of cortisol during stress. High cortisol levels are associated with chronic stress, and they impact your levels of estrogen and progesterone in the body. Elevated cortisol leads to hormonal imbalance by inhibiting the production of these hormones. And it results in lower levels of estrogen and progesterone that contributes to the symptoms of mood swings and sleep disturbances. And additionally, high cortisol interferes with the normal functioning of the ovaries and adrenal glands, which further complicates this hormone imbalance. In addition to cortisol levels, high stress levels create a cascade of number of physiological effects of stress that also put women's health at risk. Stress increases systemic inflammation. I'm going to sound like a broken record because it's the same things that happen when you drop off your estrogen and progesterone. But stress can lead to increased levels of pro-inflammatory cytokines. Chronic stress alters your white blood cell levels, and it suppresses immune functions. It lowers your lymphocyte levels and the balance between immune cells. It increases blood sugars due to the action of cortisol and adrenaline. It's a stress-related insulin resistance can be evident. It can alter your lipid metabolism. We absolutely underestimate the impact of stress on women's health. And this is also related to the fact that I don't think there's a woman that I've met that hasn't gone to a physician and will say, this is going on in my life. And the response is, you need to decrease your stress level. And frankly, I think that's malpractice at this stage, because you're not helping anyone to say you need to decrease your stress level. And I think about a woman's life, or from my perspective, actually, and having been told that, it just was a real frustration for me because I wasn't sure what I was supposed to offload. It isn't a question of who's doing the dishes or who's doing the housework. Because when you're part of a family and part of a community, you want to be at those things, whether you have, 10 minutes to be there or not. I wanted to be at the parent-teacher conferences. I needed to be at my doctor, at taking my kids to the doctor so that I could understand what might be going on in their little bodies. So other causes of estrogen imbalance include birth control pill and IUDs. And estrogen used in birth control is actually a synthetic form of estrogen, often referred as ethinyl estradiol. But while it mimics the effects of natural estrogens produced by the ovaries, its chemical structure is actually slightly different, which affects how it's metabolized in the blood or in the body. And birth controls actually fool the brain into not producing follicle-stimulating hormone and luteinizing hormone. And the synthetic hormones in the pill work to inhibit natural hormonal signals that stimulate the ovaries, effectively preventing ovulation. So this suppression is a key mechanism by which birth controls regulate your menstrual cycle and prevent pregnancies. Another cause of estrogen imbalance is IVF treatment. And IVF can cause hormone imbalances due to the introduction of synthetic hormones like the gonadotropins, which stimulate the ovaries to produce multiple eggs. And this leads to fluctuations in your hormone level as the body responds to the external hormone differently than it would to its natural hormone cycle. Additionally, the rapid development of multiple follicles overwhelms the body's regulatory system, leading to an imbalance in estrogens and progesterones. More importantly, Dr. Natalie Crawford, an infertility specialist, reports that regardless of the many reasons that the brain shuts off the production of FSH and luteinizing hormone, and ultimately estrogen, it may take up to 2 years to reprogram the brain to start the process related to this production of estrogen and progesterone. So other causes in today's world of estrogen imbalances are extreme dieting, excessive weight loss, excessive exercise, and obesity. So excessive weight loss and dieting causes hormone imbalances in women, and it disrupts, again, the HPO axis and reduces the production of estrogen and progesterone. Excessive exercise can cause hormone imbalance because it places significant physical stress on the body. And obesity in females causes sex hormone imbalance, primarily due to the presence of excess adipose tissue, which also produces estrogen. And the increased estrogen leads to an imbalance of all the other hormones. And I'd like to tell a story about how this all started to make sense to me. As I mentioned, one of my graduate students, Nicole Tagg, who's working towards her defense coming up, told me about a study where postmenopausal women underwent exercise interventions where one group received estrogen and the other didn't. So they were both exercising, one got estrogen, the other didn't. And there were cardiovascular benefits seen there were no cardiovascular benefits seen in the women who only exercised. At the same time that this happened, there was an American track and field champion, Tori Bowie, who won gold, silver, and bronze medals in the 2016 Olympic Games, who died at home of pregnancy complications that included eclampsia. And according to the autopsy report, Bowie was found dead in her bed May 2nd while approximately 8 months pregnant. Beyonce, Serena Williams, Kim Kardashian are just a few of the well-known figures who have experienced preeclampsia, a potentially life-threatening form of high blood pressure or hypertension that occurs in pregnancy or postpartum. And one thing we know that these two groups, the postpartum group and these athletes, have in common is a lack of endogenous estrogen. High-level athletes have years where their vessels do not have the benefit of endogenous estrogen. And this, in fact, led to Nicole starting to work on her PhD, and she's completed a chapter called The Effects of Sex Steroid Hormones on Cardiovascular Physiology in Females, in a book called The Biology of Women's Heart Health. And that led to a systematic review on secondary amenorrhea on cardiovascular disease risk in physically active women. And spoiler alert, physically active women, athletes, with secondary amenorrhea, amenorrhea is loss of period for 3 months or more, had significantly lower estradiol, lower flow-mediated dilation, higher total cholesterol, triglycerides, and high-density lipoprotein and low-density lipoprotein cholesterol. Nicole's work on amenorrhea is absolutely groundbreaking, but it's changing. It's going to change the way we think about it, because in society and amongst clinicians, amenorrhea is, don't worry about it, your period will come back, especially if you're an extreme athlete or you've done excessive dieting or excessive exercise. And we all think that that's normal, when actually they may be depriving their body of essential, I was going to say nutrients, but essential estrogens that keep their blood, their brain, their muscles, their bone where it needs to be. So the take-home messages here is we've really got to rethink what is normal for women and for women's heart health and all health. We know in the heart health world that early menarche, heavy bleeding, erratic cycles, and amenorrhea actually are predictive, can be predictive of risk for pregnancy complications, vascular pregnancy complications, so hypertension, gestational diabetes, things related to your vascular system. And Nicole's work is starting to demonstrate that amenorrhea is predictive of worse outcomes as well as other risk factors. But as far as I know, we do know this in the cardiovascular world, that it causes early cardiovascular disease risk in women. But we are now, the only question I've ever been asked is, when was your last menstrual period? And then, they stop asking you that at a certain time. But we do know that, like early menarche, if you have your period before age of 12, that is related to poorer outcomes as far as your heart risk is concerned. Vascular symptoms like hot flashes and night sweats, they are actually not normal. And women who present with overt perimenopausal vascular symptoms actually already have these indices of subclinical cardiovascular disease. So they already have, when they present with these vascular symptoms, if we were to do arterial stiffness measures, we'd identify that they have poor endothelial functions, poor flow-mediated dilation, less intima media thickness, all the things that are related to what estrogen does to keep your blood vessels healthy. High chronic stress levels are not normal. And as I said, telling someone they've got to reduce their stress in today's world, I don't think is effective whatsoever. And it behooves us to figure out how to teach women, how to educate women about the fact of what chronic stress is doing, but also that we need to learn how to turn off our sympathetic system and turn on our parasympathetic system. And there's actually quite a lot of literature that's coming out in this. So things like yoga and breathing and things that you can do for 10 minutes a day that actually stop that fight or flight response and try to regulate your body. The other thing that drives me crazy is suggesting that you're just not going to sleep during perimenopause. Don't worry, it'll help. It'll get better once you settle into menopause. Not sleeping is not normal, and a lack of sleep has been strongly associated with increased risk of cardiovascular disease because it contributes to high blood pressure, inflammation, metabolic disturbances. Lack of sleep is also been strongly associated with dementia. And I was listening to a book, audio book on why we sleep, a brilliant book I would suggest everyone reads. And, you know, there was this association between lack of sleep and dementia. And then, you know, you're thinking 2/3 of people with dementia are women. And I don't think that's a surprise because after babies and during perimenopause, it's like you don't sleep at all. And I think we need to take this way more seriously than we ever have. Why this paradigm shift is essential now is that I recognize that I presented a substantial amount of information. However, if we're serious about achieving a true paradigm shift in women's health, we have to understand how we arrived at the current state of care. Historically, medicine focused on women's ovaries as being all about fertility and controlling fertility. And I started a short paper on looking at, through history, the control of our ovaries has been part of our culture, and even in the States today that's going on. And it really struck me when I was reading a wonderful book called the Musicians of Auschwitz, or the Female Orchestra of Auschwitz, and a beautiful story, really interesting story. But one of the things that I read in that book that just struck me is that one of the experiments that they were doing on women in Auschwitz was radiating their ovaries in an attempt to control their fertility, and actually radiating from the front and back. And so those that even survived the radiation and may have survived Auschwitz, you know, I'm thinking in the back of their head that they're not producing estrogen or progesterone at all. And it's so important in all of our bodily functions. And it narrows the lens and has profound downstream consequences for women's bone health and cardiovascular health and metabolic health if we don't think about what's going on in the ovaries. And central to this problem is the persistence of bad science and misinterpreted evidence. Most notably, I want to talk about the legacy of the Women's Health Initiative, which entrenched this false narrative that exogenous estrogen universally caused breast cancer and heart disease. And this conclusion is simply not supported by the totality of all of the evidence, and mostly the contemporary evidence. But its impact continues, and we don't look at individualized care at all. Every woman deserves access not only to a single prescription, but to meaningful evidence-based discussion about what the options are for them moving forward across the lifespan. And this same principle of choice, my friend and colleague, Lisa Galea, was noted, and it really struck me, Lisa, it was like an aha moment for me, that women have long been encouraged to try multiple combinations of drugs and therapies to prevent pregnancies. So why then isn't the same principle of choice and personalization and shared decision-making not extended to post-reproductive care, particularly when we know what estrogen has been well established as far as the benefits are for the bone and the cardiovascular and your brain health? Addressing this imbalance is not optional. It's actually essential if we're to correct the decades of structural neglect and advance equitable science. So if I can get this slide to move, one more. Oops. What happened there? Are you still seeing my slides, by the way?
We see your screen.
Oh,
Like your Zoom.
yeah, it went right out. Okay. I want to put up the slide because I have so many people to thank.
It's your
Put it up
acknowledgement
there.
slide. Thank you. Thank you for the shout out there.
Oh, no, it really, really got me thinking. And I'm gonna
Yeah, share your
stop the share and then I'll share it again here. I'm sorry, seem like such an amateur at this.
you're passionate.
Okay, I want to put up this side. I'll just put my presenter layout here. Okay, I'm going to just share this for sake of. Can you see my?
Yes, women's health matters. Yeah,
Okay,
it's
so
presenter
we
mode, but
are a women's health research group based out of the University of Alberta, and I just wanted to talk about this and ask, have people go. Our mission is to generate the evidence that we need to carry on, and it's YEG, YEG, that's short for Edmonton, women's with an S, research.ca. One of the other things I wanted to show you is that we're going to be opening the first publicly funded in Canada virtual primary care NP-led post-reproductive transition clinic starting in February. And it's to support women through their hormonal transitions in the late reproductive stage and perimenopause and menopause. And
great.
we also are launching a big study that Lisa was involved with that we talk about. We are trying to create awareness and understanding for women about reproductive aging, talking about what I've talked about, because most women, this is new to. The only thing we ever learned is how not to get pregnant. We don't know anything else about our estrogens and progesterones. And so this is the group I wanted to thank. So it's Alberta Women's Health Foundation, University of Alberta. I've had CIHR and Heart and Stroke, CK Huey Hospital, the Royal Alec, Women and Children's Health Research Institute, and the Lois Hole Hospital for Women. And to all of the people who work with us, Maya Henriquez and Nicole Teg, and all the students, the master's and honor students, I'm so grateful to be able to move this science forward. Thank you very much.
Well, thank you to Dr. Norris. Please, if you are on screen, please give a little virtual thank you, Laura, for giving the little clapping and the hearts. Thank you. It's always so nice because it's hard to give these virtual talks because you feel like people aren't necessarily listening. Colleen, that was like a master class in terms of trying to understand a number of the challenges in this in understanding the sort of cessation of cycles. I really appreciated a lot of the themes that you touched upon, and I have written down a few things to talk about and ask you about. But before I do that, I wonder if there's anybody that wants to ask a question, either in the chat or um or if they want to raise their hand and ask a question. But otherwise, it's just, Lisa Galia talking to Colleen Norris, which is fine because I'm going to have her on the podcast. So you hear it, but you'll hear it then too. Okay.
Emily has her hand up, I think.
Emily. Oh, great. Emily, please. So does Laura. Emily or Laura? Laura has her hand up.
Yeah.
Whoever. Emily. Laura, go ahead.
Hello.
Hello.
Thank you. Sorry for that delay. Thanks so much for your talk. It was fantastic. Gave me lots to think about. Um, my question is pertaining to hormonal contraception. Um, I think there's some really interesting information you shared with related to hormonal imbalance and how hormonal contraception can be a contributing factor in that respect. Um, I think it's always hard for me because I wonder about the hormones within hormonal contraception and how much of that is actually disruptive or maybe can be also viewed as potentially something that might be helpful in some respects, but maybe it depends on the type as well. I guess where I'm kind of speaking from is I know ethinyl estradiol is a synthetic form of estrogens, but it binds really strongly to estrogen receptors in certain areas. So I just wanted to pick your brain a bit more about your thoughts on hormonal contraception.
I, I, it's out of my bailiwick, to be honest, because as I said, but having said that, I think the reason I bring that up is I think that women think, well, I'm on estrogen in my birth control pill, so I'm okay. And so it really depends on what receptors that binds to. So there's a lot of women in the age of late 30s to say 45 that are going enough that the Seattle group called it not feeling like myself, who are on birth control pills or some form of birth control, that go into the clinician and said, this brain fog, like there's something really wrong with me. Three of my colleagues down in Calgary went and got MRIs. They thought they were getting early Alzheimer's, right? So the stuff that you always remember. So those of us that have access to those sort of things can sort of work it out. But the everyday woman on the street is thinking something's really wrong. But the first question you get asked if you go in at that age is, any changes in your period? No. And that was my response too. I was on birth control. I was 42 or around 42. And I said, any changes? I said, I'm not in menopause. And so her response was, it must be depression and let's try an antidepressant. And that was a long time ago, but that's still what's happening today. And the specialities, we've gotten into looking at brain health or cardiovascular health or liver health or kidney health, and you completely ignore the essence of what women's health is all about.
I think, do you think that that's a part of why women's health in general has been ignored in the sort of medical field, if I can put it that way? I know those are strong words, but because it's whole health, right? It's not just there's been a lot of attention paid to reproductive health, actually, but not for other forms of health, as you mentioned, bone health, heart health, brain health, kidney health, I'm sure, lung health. I'm sure all of we know that all of it will matter. So I'm wondering if that's part, medicine itself is sort of is a disease focus, but also sort of siloed in terms of sort of organs and systems rather than a sort of whole body approach. And do you think that contributes?
You're absolutely right. And when I'm in the division of cardiology, so I go to these meetings and we're saying, well, I just don't understand why women are presenting differently. No, we can understand that if you want to, but and it's had this, excuse me, this cyclical thing of, in the 70s, we were a big promotion, all of our mothers and raging and saying women's health, and we're going to define what women's health is. And then that dropped off. Women are just the same as men. Why would we do that? And I have colleagues today that say, I treat the women in my practice exactly the same way as I treat the men. I said, that's the problem, right? Because, even I have books I'm picking up where we're spending so much time on defining a female and a male and a man or a woman. And I think that's important work to start paying attention to that. However, what gets lost is what are the biological differences aside from the psychosocial role differences, and how do we move that forward? And I've really noticed it in all of the stuff that's coming out. It's like it's a battle for women to get any kind of hormone therapy. And I'm specifically dropping off the R, replacement. It's hormone therapy for older women, same as hormone therapy for you not to get pregnant. We're going to give you hormone therapy for perimenopause. It's absolutely crazy to me that you have clinicians saying evidence is bad and you'll have to find another doctor to do that. That is unconscionable to me because they don't know what they're talking about, to be honest. The evidence is not there. There is no... I've been trying to dive into, if you've had a heart attack or you've had any kind of heart event, then hormone therapy is off the table. This is after you've had the heart event. And I'm trying to, where's the evidence for that? I'm digging everywhere. There is no evidence to say if you've had heart disease, even what are the mechanistic reasons? Why would that be? Like what are the mechanisms that would cause that if you took a hormone therapy after you've had a heart event, that it would cause more heart events?
I think so. There are a couple of questions in the chat, or one or two questions in the chat. And one thing before you answer, I think the answer is going to be we need more research. So there
Oh,
isn't a lot of research out there on a lot of the things that you think of, like, oh, it's don't worry, it's normal, it'll bounce back. We don't have a lot of
no.
research to support any of those kinds of statements. So the question from Marie is, as a family physician, what's the best thing instead of just saying you need to control your stress levels? What strong evidence is there with regards to stress management, which I think you mentioned meditation, yoga. I mean, it's going to differ for everyone. Meditation for me doesn't work. When is menopausal hormone therapy something to consider for cardiovascular disease prevention?
You know what? I went to it was a wonderful show in Toronto, actually, was the menopause show, and it's put on for women, but they do have incredible experts up there. And I went this past year, and it was the first time ever they're saying it's preventative. So if you had family with heart disease, or even if you just want to improve your heart function as you're getting older, we should be talking to women about this. It may mean that you should have some estrogen as you're going through perimenopause, or at least thinking about what your body is doing. And like if you have high blood pressure at 35, there's something going on in your circulatory system. And you know, it the stress question is, we're trying to pull up the evidence on that. Like how else? Dance therapy has been used,
Mhm.
sleep, music therapy. I was
Mhm.
on a wonderful study. We're figuring out what music you like and actually just plugging in
Mhm.
those sound waves to you for 10 minutes a day.
Mhm. One of my favorites is retail therapy, but not
Yeah,
everyone can afford that.
yeah.
Um, and one of the studies that you talked about was exercising and the benefits if you were on or off estrogens. And I thought that was really interesting because in the animal literature, which I know very well, we actually see the same kinds of things. You see more neuroplastic effects, benefits of exercise, and BDNF, all these sort of trophic factors that you want to express, only if the female mice or rats were also on estrogens, which I think is really, really interesting. So to see that also recapitulated in humans is
In humans. And
fascinating.
what
Yeah.
blows me away about that is that the American Olympic Association hasn't figured that out, that, maybe their athletes would perform better,
Yeah.
if they were on estrogen.
hmm They won't let allow anything like that though. Um, okay, we're out of time, but there are so many other great questions, nutrition-based recommendations. What happens if you have a tr stroke? But you know what I'm going to do is I'm going to put a pin in that and try to get speakers that can speak to that, as well as ask Colleen to hopefully write a blog and answer some more of your questions for the Women's Health Research Cluster, but also take a listen to the web-based, or try to participate in Aura, some of those studies that Colleen's doing out of Edmonton, and follow along in her own, what's it called again? YEG, womenshealth.ca.
YEG Women's
Ah,
Research.ca.
got it. Women's research. Yes. It's key, key, key. Anyway, thank you so much. I'm sorry to cut it short, but I know everybody has other things to do. But this was really fantastic. And thank you again, Dr. Norris, for your insights.